Good evening, everyone. Welcome to the Medventions lecture series. I see some Medventions first-timers, so I'd like to give you a very quick background on the Medventions program first. So the Medventions program is Sunnybrook's training program. We developed this program here to help nurture the next generation of Canadian medtech entrepreneurs. Our program has several key components. The first is we offer Medventions, what we call the Medventions Innovation Fellowships, which is basically a 4-month training program where we bring in multidisciplinary teams of clinicians and engineers and other healthcare professionals and get them immersed in the clinical environment here at Sunnybrook, where they get tasked to look for clinical challenges that really impose a significant medical burden and try to come up with novel solutions for these challenges throughout the 4-month training period. The second key component is our annual Innovation Day, which is taking place this year on December 12th. So save the date from now. It's a full day where we bring in local and global speakers to come and share their learning points and successes and stories about how they move their innovations from bench to bedside. The third component is basically the lecture series, which this lecture is the first of a series of lectures taking place this fall. For the next 12 or 13 weeks, we'll be having a lecture every Thursday in 5 o'clock in this room, and we're going to tackle many fundamental topics in the challenging path of how to take an innovation from concept to market. I'm very delighted to be introducing today's speaker, Dr. Anne Snowdon, who will be discussing the healthcare innovation landscape with an exceptional perspective on some key global trends in health system innovation. But before I get into specifics, I would just like to make some very quick announcements. Our next lecture is scheduled for Thursday, 14th. We're having Dr. Brian Courtney. He's an interventional cardiologist, founder of Canavi Medical, and he's also the director of the Medventions program here at Sunnybrook. He will be discussing how to perform clinical observations, how to look with an innovator's lens on clinical challenges, and also how to perform market analysis. The second lecture, the following one, is on September 21st, and we're having Mr. Robert Harrison, R&D Manager, Spine Division at Baylis Medical, and he'll be using Baylis Medical as a case study to walk us through the medtech entrepreneurship. So currently, for Sunnybrook people, we are no longer able to use the global mailing lists. So if you wish to receive information about our innovation activities, please do subscribe to our e-newsletter, which is located at the website sunnybrook.ca/medventions. For this fall, we're using Zoom, the online platform webinar tool, so remote participants can actually join us. Hopefully they can hear us and see us now, and can actually interact with our speakers if they cannot commute to Sunnybrook. Finally, for the medical biophysics students who are taking this lecture series as the course module, the Medical Device Innovation Entrepreneurship course module, your orientation session is scheduled for September 14th at 4 p.m. in this lecture theater, right before Dr. Courtney's lecture. Shifting gears to today's lecture, so for the next hour, we are very fortunate to have Dr. Anne Snowdon with us tonight. She will be giving us a better insight into the healthcare innovation landscape, and again, with a very special perspective on key global trends on healthcare, in health systems innovation, and very much like her report titled the Transforming Canada into a Global Center for Healthcare Innovation and Adoption, a very influential report. I highly recommend that you read it if you didn't. She wrote it, I think, a few years back. It's an amazing read, and it really shows how, like, Dr. Snowdon's views, analysis, and observations can help us better tackle the challenging path of developing medical technology innovations that could potentially contribute to Canada's healthcare innovation sector. A little bit of a background on Dr. Snowdon. She's a professor and academic chair of the World Health Innovation Network and the scientific director and CEO of Scan Health, a network of centers of excellence international knowledge translation platform located at the University of Windsor's Audit School of Business. Dr. Snowdon works to build collaborative partnerships around the globe to advance innovation and scalability of innovation across health system to strengthen performance, economic value, and sustainability. Currently, Dr. Snowdon is leading over 10 innovation research initiatives across 7 Canadian provinces and 5 countries. Dr. Snowdon has published more than 140 research articles, papers, and cases, and received over 22 million in research funding. And she's been actively engaged in commercialization activities. She holds a PhD in nursing from the University of Michigan and is a Fulbright scholar. Dr. Snowdon, welcome to Sunnybrook. We're very much looking forward to hearing your talk.
Thank you so much, Ahmed. It is absolute pleasure to spend time with you today. I'm going to do my best to not move, because normally I would walk all over the room. And I'll very much look forward to your questions, your comments, your thoughts. It's a very, very interesting time in health systems, and we talk a lot about innovation. What I'd like to do tonight is really walk through what some of these trends are, what's emerging, what are future health systems really going to have to grapple with. And for me, they may sound like horrific challenges, but in fact, for people like yourselves in this innovation space, developing new thinking, new ways of developing technologies, products, devices, models of care, it is a massive opportunity for you, but very much one where we're going to need game-changing technologies and thinking, because the old models of health systems are just not going to be sustainable for that much longer. So let me walk you through some of the challenges globally all health systems are facing. I'll show you where Canada is aligning in terms of some of those challenges, and then talk about some of the trends that you might want to think about as you move forward in your particular work. Not shocking for anybody, our health systems are wildly expensive globally. When you have a look at this map, North America is very much ranked at the bottom. We spend a greater percentage of our GDP than any other sector in the world, although when you pull the American and the Canadian systems apart, we look a little better than we look on this slide. All to say, healthcare globally is far outpacing the GDP most countries are able to produce, and given many of them are publicly funded, if we continue to spend more money than our country is able to generate in terms of growth and wealth, then we're going to have a very, very difficult time in terms of supporting these health systems. In Canada, just a brief example of how significant a challenge that is. At the moment, we're spending about 47 cents on the tax dollar to keep our health systems funded. If we change nothing about our health system today, and we remain a very expensive and hospital-dominant system, which is pretty much what we are now, that number will go up to 70% of the tax base. So there's no new money coming into our tax revenues. So what in fact will happen is health will start to consume funds from other larger sectors like education, justice, social services, and really that's not an option for us. So in many business schools, we talk about the burning cliff or the burning opportunity for change. We are certainly there in healthcare. And we're probably now more open to change and innovation than we perhaps ever have been, because the money is just not going to be there today and moving forward to support this very expensive system we have right now. How much do we actually spend? We actually don't always know this. About $215 billion annually in Canada. It is 11% of our GDP at the moment. It is somewhat plateauing at 5.5% of our GDP growth. There is expectations again that will increase unless we start to, as you've heard this many times, I'm sure, bend the cost curve. The question is exactly how do you do that? And we'll talk a little bit about that tonight. What do we spend that money on? 62.6 billion is just hospital care. The #1 spend in hospital care is actually people. So it's those highly educated, very talented workforce that are expensive. Canada has among the most highly educated workforce in the world. Often ranked 1, sometimes slips to second only to Finland. And we are often recruited globally because we're so highly trained, and the level of standardization of our training in clinical settings in our universities is extremely high and very consistent. So we're a global asset for the world's health systems, and that often worries me in terms of health systems that are much larger. The Americans is, the US is one of those, where they very quickly recruit the talent, and particularly in entrepreneurs. We have phenomenal Canadian companies, small and medium-sized enterprises that get very quickly, almost literally bought and sold and located in the US. So we've supported them all through their education, their innovation, prototyping, product development, and yet Canada so often does not reap the benefits of the market growth that they can achieve. So this is a really significant issue for us, and one as a country we really have to overcome. Drugs, we spend a lot of money in drugs. We have the challenge of getting all the drugs to all those remote communities in a very large landmass. So distribution of drugs and where and they're needed and for whom is not a small challenge our country faces, and that obviously is not going to change anytime soon. And physicians is the other big spend, $31 billion, not too far out of the realm of other countries, but again, a precious resource, and one I think we have to think about quite carefully in terms of retaining and strengthening. So for the money we're spending, the million-dollar question any school would ask you is, so what are we getting for that investment? And we're spending quite a bit more than many other countries, but when we are compared in terms of its ranking, in terms of performance, we do not fare as well as we should be. We're ranked actually 10th out of 11. But that's a really probably a crummy number to be to be given all of the assets we have to work with. This data is a little bit old. Commonwealth Fund just published the most recent. We've moved from 10th place to 9th. So hang on to your hats. That's not exactly cause for celebration, but at least we haven't moved to 11th. And at one time, it was very concerning that we would hit 11. And then they elected our dear friend, Mr. Trump, and there was no concerns now that we're going to hit 11 because he seems to be able to blow up systems rather quickly. So if you look at, especially in healthcare, if you look at those columns under those flags, a good thing is lots of green. A relatively poor thing is lots of orange. We have no green. We rank nowhere in the top 2 of that small group of countries, and yet we need to, because we have phenomenal assets to bring to health system performance. I'll talk a little bit about why is it that we haven't achieved some of the outcomes that I think we're very, very capable of. I'll speak a little bit shortly about why is UK ranked number 1. We hear all kinds of problems about the NHS in England, but despite those challenges, they spend almost 40%, close to 50% less than we do, and look at the rankings in terms of number 1 and so many of the performance outcomes. In the most recent data where we're now ranked 9th, they are still ranked number 1. And given some of the work they're doing that I'll share very briefly tonight, I expect them to be number 1 for a very long time. They are at least a decade ahead of us on some very important system level challenges and initiatives that are worth learning from, actually. What are some of the other issues around health systems in Canada other than the money we're spending and the quality we're not actually achieving in terms of performance? Well, this is no shock to anybody. The aging population is not going to be easy. That big bubble called baby boomers is hitting the health system pretty much now moving forward. We'll talk a little bit about that group and that population segment, which is important. But by 2030, a third of our country will be over 65. That is going to be a very different landscape. So we'll talk a little bit about what that might mean and where there is an absolute phenomenal opportunity for innovation and entrepreneurial thinking. Here's the one that probably worries me the most, more so even than the aging, and that is the rate of our chronic illnesses. Given we have, now think about this, a very hospital-dominant system, I can't think of an organization that actually really has the ability to offer the chronic illness care strategies we need to. When people come into hospitals with chronic illnesses, and you've seen them many times, I'm sure, that means we're not managing those chronic illnesses in the communities where they live as well as they should be. If they need hospitalization, then we're missing a boat, and that's a bit of an issue. 3 out of 5 Canadians over the age of 20 have at least one chronic illness. Our next generation of Canadians, Canada's children, is the first generation in our country's history that may not outlive their parents. And most of that is because the very high rates of obesity in that very young population. So they're healthy kids, but they're too heavy. And when they hit about 35, 40, they will start to show some of the challenges with heart disease, of course, and blood pressure and all the rest. The other issue that's scary on this data, and this is Public Health Agency of Canada, is the rates of hypertension. So that gray bar is the growth anticipated out to 2039 on the rates of hypertension. Hypertension is absolutely the contributor to some incredibly serious challenges. Kidney failure being a very early one, where the kidneys really take a hit with prolonged high blood pressure. But the other one that's very interesting is dementia. 46% of dementia is a major contributor is high blood pressure. So much so that England and NHS has now launched a dementia prevention strategy. We have no clear, obvious treatments, cures, preventive strategies for dementia. They've gone way down the road on let's prevent it by keeping people's blood pressure aggressively down and much lower than previous generations. Because if that means we can prevent 46% of the population who would otherwise experience dementia, that is a massive lift and decrease on burden in terms of our health system. So that's one that I think is very much and a good opportunity to be thinking about, is how do we help people help themselves get their blood pressures down and keep it very low so that we offset the very devastating challenges of some of these chronic illnesses. Notice cancer, pretty flatlined over the next couple of decades in terms of prevalence, which speaks to the tremendous innovation, therapies, research dollars we've put into it. Phenomenal, but we haven't had quite that level of attention perhaps to some of these other areas that I think we could really consider carefully. Utilization of healthcare is a big issue. We talk all the time about access. We talk about we talk about wait times, and here's some work by Walter Woodchis, an ISIS scientist, which was really an eye-opener. This data has been repeated across most every province in the country, all to say that about 67% of our health dollars in this province, but it's been replicated in many others, are consumed by 5% of the Ontario population. That's not very many people. So if you zero in on why are 5% of us consuming 67% of our health system resources, that's an opportunity not only to start to address these sustainability issues on health system cost, but it certainly also narrows us very nicely into the population segment that most need innovative tools, devices, approaches to care to keep them well and keep them out of hospital and consuming so many resources. You'll notice the big blue bar on the bottom, that's 50% of our Ontario population. Costs our healthcare system about $180 a year. So part of the issue is not just the top 5, how do we figure out much better ways to keep those people healthy, and I'll speak to a project we've done with that one. It's how to prevent that 10%, the big green, becoming your next 5 and your next 1%. Your 1% tends to be end-of-life, multi-comorbidity, highly, highly complex patients. And because they're so end-of-life, that might be a different approach, but that top 5% and the 10 coming in behind it are a very important population segment to keep in mind. But guess what? If today the health minister said, yes, let's put all these resources into helping that 5%, we actually don't know who they are. And I'll speak to a bit of a study. We don't track and trace anyone across the journey of care in healthcare to know that Lori Turek is a high user 5%, and she's still a high user 5% from the spring, and now it's the fall, and what have we missed in order to know how best to help her. So I'll speak a little bit to the system infrastructure challenge in front of us and some really interesting opportunities to figure out who are these 5% that utilize this incredible level of resources in the system, and how do we follow and track them over time to make sure they're no longer the 5% because we've figured out a much better, more successful and impactful model of care. Here's another big challenge. This one's growing, not shocking. As healthcare becomes more complex, comorbidities, multi-chronic illnesses continue to increase and grow over time. Patient safety is probably one of the most intractable problems many health systems have, but I would suggest that North America's health system really haven't moved this needle at all. Ross Baker at U of T did the seminal work in 2004. Now, how did he measure that we have 70,000 Canadians experience preventable harm and 23,000 deaths? Any guesses? Let me help you with that. He did a randomized chart review by hand and went through every patient chart that was randomly selected to figure out what number of patients experienced preventable harm, how frequently did it happen. There's something wrong with that picture. How are we ever going to address patient safety if we have to take 2 years, randomly pull charts, do long and deep in-depth chart reviews to figure out what's our rate of error? A clinician, I'm a nurse by training. I spent about 10, 15 years in pediatric intensive care unit. If you come and tell me today, guess what, our error rates are X, it's based on data from 2 years ago. What might I, pray tell, do with that? We need much better processes in our health systems, and this is the infrastructure challenge to track and trace. How did we do today? On construction sites, you see those big thermometers that says we've had only 2 workplace safety accidents today. We do nothing like that in healthcare. So how can we expect clinician teams to improve on patient safety when we don't know what patients, what types of error, how could we have prevented them, and giving us some cues proactively in our clinical settings to know when someone's at risk so we could be extra careful to avoid them. So I'll come back to that shortly, but it worries me, and it's probably the one thing that drives me crazy in healthcare among all the other data I just shared. Medical errors are 3rd leading cause of death. How is that possible? 3rd, after heart disease, cancer. That means higher than anybody higher than our prevalence of COPD or many of our other chronic illnesses, mental health. So think about that. I think that's probably one of the areas we have so much opportunity, but we don't always think about it in terms of an entrepreneurial innovation, strategy, technology space that I think we could be. So as clinicians, what do clinicians do in the current infrastructure and health systems if medical error is so prevalent? Well, Ross and his 2014 study went in and looked at what are clinicians doing and found that 1 in 4 patients, clinicians are caring for people without all the information they need. 1 in 3 patient interactions, the equipment is either not working or not functional or not available. Now, you can report on these every time they happen, but what happens in clinical care, and some of you may be already down this road, I know it was certainly normal for us, is it becomes so normal that things don't work or things aren't available, you just make do. Nurses are brilliant at workarounds, surgeons even better in real time. And what we do is just don't bother. We don't report, because we don't think anything will change because it's that common. So those numbers on terms of 70,000 preventable events, 23,000 deaths are widely viewed as underestimating and highly conservative. Colleagues to the US, it's 250,000 deaths every year, and it's pretty typical with our population size. There are some that say, oh, I don't think that's right. It can't be that frequent. When I did the lit review on that one, I have to tell you, there are not 1, there are 50 studies for the last 15 years. And the numbers they're reporting, no matter what methodologies, what statistical validity they had, were all that high. So it is there, and I think it's an opportunity that we need to be thinking about. But I also think it's a phenomenal opportunity for entrepreneurial thinking. We can't keep doing the same thing year after year and expecting a different result. A stat, part of this one also drives me crazy. We share with Australia the highest rate of foreign bodies left in surgical cavities. There's something wrong with that picture. I'm doing some work in supply chain. I'll share that shortly with you. I had a hospital team say, very excitedly say, Anne, you know, we've really done a cool innovation in our operating room. I said, great, any innovation, I'm all in. They're using orange garbage bags. So at the side of the case, you throw everything you use in the orange garbage bag, and then we can count it and make sure we didn't leave anything in the cavity. So great, thrilled that they're addressing and trying to figure out a way to do that. But I'm pretty sure if you ask the guy in the grocery store, how do you account for products on a shelf, products that get purchased, products that get recalled? They'll tell you. Well, it's a simple barcode. You scan it, you know who bought it, you know where that food came from. If it's a tomato, you know the vine they picked it from in which greenhouse in Leamington, tomato capital of the country, and they can track and trace that in an hour. Ask yourself the question, how quickly could we track and trace what contaminated tomato ended up on a patient's sandwich on a lunch tray in any Canadian hospital? And the answer would be, we can't. But that's another opportunity that I think we're making some progress on. I'll share with you shortly, and that's really the NCE we were just funded on. Now, I've shared some fairly bad news on the rates of error in hospital setting, and that was Ross's work. There's almost no data on error in the community setting, and yet most of our chronic illness care is moving towards communities, and it should. We have no system to track error in EMS, virtually no data on error in primary care, and when we do chart reviews in community settings, the rate of adverse events that are preventable is actually double that as a hospital. Children's hospital, double the rate of an adult hospital. So there is something to this pattern, and I think it's something Canada actually could lead on. There are not many countries in the world that are actually achieving significant outcomes on that yet. Just a quick one as well. This is where we're ranking and comparing to other OECD countries. We're better than average on post-op sepsis, and a lot of the research I know has come out of the Toronto hospitals has done phenomenal stuff. We're very low and below average on OB trauma, post-op DVTs for hips and knees, and post-op pulmonary embolism. So we have a long way to go, and it's not a popular subject in terms of error, but it is one that I hope we can mobilize and partner a number of different areas of expertise to address it. These are broad estimates of how much do those things cost. They cost a tremendous amount. I would say $397 million for a Canadian cost of patient safety would be pretty low. This recent study in England on the cost of unsafe care are putting it at the 1 to 2.5 billion British pounds. And in the US, of course, it's also phenomenally high. So let's talk about innovation in health systems. And how do we drive it, and how do we make it happen to a much accelerated rate, but how do we embed in scale at the health system level? Just so you know what our work does, Laurie's the executive director at the World Health Innovation, I'm the lead researcher. We take innovations with documented evidence of impact. So you create the next generation of a medical device, you put it into a clinical setting in Sunnybrook, you create the evidence that this has real value. Once that happens, that's where the World Health Innovation Network works with you to embed and scale across systems. We have phenomenal numbers of innovations across the country. We are not at all talented at getting them into our systems and scaling them so every Canadian has the opportunity to have advantage of those innovations. But just as importantly, those Canadian companies that emerge out of programs like Medventions become rapidly and are able to achieve a rapid market growth and be economically very, very successful. We want those companies to make millions and trillions of dollars because they are that successful at scaling their products, and that's the work we essentially focus on at the WIN Network. We're not the group that helps people develop those technologies. We're the ones that help you get into the systems where they need to. Based on our experience in healthcare, this is a quote by a favorite quote of mine from Henry Ford, who said, you know, if I'd asked people what they wanted, they would have just said faster horses. One of our problems in health systems is we want more money, more operating rooms, more emergency room staff, more clinics. We want more of many things. And so far, Canada's thrown a lot of more of many things at healthcare, and we've never changed our outcomes in terms of performance. What we really need is rethinking, taking what we have, the assets we have, the tremendous talent, ability, the resources we're pouring into different aspects of healthcare, and figuring out how to make it work for us, at the same time driving our economic growth and GDP, because that's what we really rely on to fund this system. So that's essentially the mandate of our center. And here are some of the trends I think you might find interesting in terms of areas of focus for the entrepreneur, the innovator, and market growth where we see tremendous opportunity. One of them is the future health system that embraces this new empowered consumer, not thinking them as patients that are just here to follow our orders, but patients who become partners in care is the system that will be wildly successful. And the focus of future health systems, at least in the research we're doing and many of the trends we're seeing, it is not so much come in and we will provide care for you. It is you come in and we'll help you manage your health so you stay healthy and well and you don't need us. It's a little bit like talking yourself out of a job, except with the numbers we have, that will be unlikely to ever happen. One of the reasons that's so important is who are the consumers of today and moving forward. And this is a graphic that came out of the New Yorker, which I think captures it well. Uber, largest taxi company in the world that does not own a single vehicle. Airbnb, largest accommodation provider in the world, doesn't own any real estate. Do you find that kind of odd? These groups never existed. This is the new business models where consumers are deciding, yeah, you know, I have a car. I don't always need it to go to work. I have days off. I can make a bit of money. They become an Uber driver. Or they use their home for an Airbnb provider. The business models of today and moving forward are not going to be the ones. And I think this trend starts to define where and how we might see some interesting things in terms of innovation in healthcare. This is also a shift in consumer culture. And for those of you in the audience that might be old enough, this might resonate. And for the young people in the room, I'm sorry about the generational effect lesson. I promised my kids I'd never do that, but I tend to be doing it. My parents, these are the baby boomers, particularly the older baby boomers. And these are people who are very used to just wait in line. I've always had to wait for my specialist appointment, and they're okay with that because that's what they've grown up with. Many of them grew up in families from the Depression. They waited for many things, and they were grateful, very grateful to have what they had, and they hold healthcare very near and dear to their personal identity because they know what it's like to go without. They really value stable relationships. This is the older population that will go to the physician because, you know what, I used to play bridge with his mother, and she was so nice. So I'm going to go to him. Relationships are everything to this group, not so much in the younger group. They are very loyal to brand. In certain day and age, when you were kids, you grew up, you were the Ford family, you only bought Ford cars, or you were the Chrysler family because you only bought Chrysler or whatever the car was, because loyalty to brand really, really means something to this group, and they will be very, very loyal to the physician or the clinicians they work with. They see health as a service, and they are very much likely to defer to the expertise of the physician or the clinical team. This is the group that grew up pre-internet. There are a few of us in the room, but pre-internet means you had no access to health information. You couldn't exactly easily find your way through the medical sciences library, go to the stacks, pull the latest journal on what's the best practice for this particular heart arrhythmia. That was unheard of. You just, the group that have access to all that information were clinicians. They're the experts. You listen, you do what they say, and you'll feel better. That is not today's consumer. Today's consumer, our children, I guess, not very patient. Everything's in real time for you guys. Everything's on your smartphone. You are watching the world unfold as it happens, not on the newspaper 24 or 6 hours later. You're extremely super connected. Any patient in a hospital today is likely to be super connected, but particularly this generation. Generally, these are the millennials, but it's not limited to this group. They are very loyal to value. They don't frankly care what the brand is. Does it give me what I'm looking for? Great, I'll buy it. If it doesn't, I don't care what name is on that label, and because they simply don't have that loyalty. Health they see as a right, and they also are the type that go in, decide what they're looking for in a healthcare provider team. They do the research. They look at everything. This is the Dr. Google crowd comes in with the list of questions that they should be asking. They interview the provider team to decide if they're worthy of working with them. This will completely shift how our clinical models are going to change. We were all socialized as clinicians to be the expert and to know how and what and direct families and patients accordingly. This is a group that says, no, I'm not interested in that. I'm interviewing you to decide, are you good enough, and are you the kind of person that can work with me to get where I want to go? That is not how our health systems are organized. We have things called best practice, clinical pathways. Clinical pathways, based on great research, say you should have 2 days of physio for this, followed by 3 days of something rehab or medication, etc. This is not a group that's going to follow our clinical pathways. This is the group that's going to say, no, this is how it's going to be. I'm going to go to this physiotherapy because I know her and I've researched her and she's got the best outcomes. And I'll tell you exactly when I'm coming back to see you because I'm not sure I need to. And they will start charting their course forward. It may or may not the best course forward, in which case the clinician becomes the negotiator, not the prescriber. And this, I think, is a phenomenal opportunity in terms of how do you create the next generation of digital tools that are going to be mapping onto the value stream of that particular generation. Here's another interesting consumer demographic we often don't think about, but thanks to Prime Minister Trudeau, we're starting to. Women around age 47, 48 in Canada, when you look at our consumer demographics, they are now caring for aging parents more years than they're caring for children at home. Now think about that for a second. Majority of women are in the workforce. They've got kids they're navigating and trying to keep safe and out of harm's way and make sure they're off and running. And they've got aging parents at home that they're trying to navigate to be sure, have they taken their medications? Have they eaten today? And yet they're doing that with almost no help in terms of apps and digital tools that help them stay connected. I took my mother into emergency one time for a fairly significant health challenge. The first thing they asked me, she's now 91, she has Alzheimer's and she has macular degeneration, so she's blind. First question they asked me is, who's her power of attorney? Me. What medications is she on? No idea. None whatsoever, because I don't have an app that actually gets loaded and uploaded and refreshed often enough. Oh, when's the last time she had a tetanus shot? Another good question. No idea. I had my son in emergency pneumothorax a few years ago, and they said, well, has he had a tetanus shot? I said, you know what? I'm really sorry. I don't know. You know what the nurse said? Well, don't you have his little yellow card? It's like, okay, wait a second. He's 22. I had that little yellow card when he hit school because he got sent home from grade 1 because I didn't have it filled out. I'll never forget that. I was the bad parent. And we're still relying on the little yellow card and Emerge. Now, I'm sure Sunnybrook Emerge does maybe better things, but it speaks to how poorly we've adopted technologies to help these women manage aging parents at home with all kinds of challenges, health challenges, and their kids, and their own work life, and their own health. In fact, I was at a sobering talk in Washington, D.C. a few weeks ago. 43% of municipalities in the U.S. are now reporting a decline in life expectancy for women. And somebody said, well, I wonder why that is. Oh, well, not surprising. We've added to the burden of women and what they're trying to achieve with workforce and career development and aging parents living much longer than they have in the past. And women, most of that work falls on the shoulders of women and children that tend to live longer at home or stay longer at home. So it is an area, this is a population that will adopt any technology that makes those multiple roles better and easier to navigate, because those roles are not going away anytime soon. The boomers is another really interesting one. I won't spend a lot of time on that one, but what's interesting about the boomers, apart from the fact that that's such a big population segment, is they are extraordinarily wealthy. 47 times the net worth of the adult population be coming up behind them. They also have a very interesting set of values, unlike any other population segment. One of them is agelessness. They look in the mirror, they may be 72, they see a 35-year-old. Not shocking. And some of us are in the audience saying, yeah, that's me. Not shocking. Botox is the absolute most heavily prescribed and used medication. It is not for muscle spasms as it once was. It is for making that face look 35, not 72. They are fiercely independent. Any clinical trial that says, oh, you know, you really should be thinking about, you know, retirement living. No way. My way or the highway. They are not. This is not that population. And personalization is their theme song, My Way. They will probably, they have completely changed every social system they have ever come up against. They will probably change healthcare for us rather than with us, because this is not a group that will take no for an answer. So that's another group where any entrepreneur should be thinking about. Digital tools, Canadians, oddly enough, spend more time online per capita than any country in the world. Not sure exactly why that is, but maybe some of you can help me with that. 44 million apps. I did this study in 2012. I'm sure it's different now. 44 million unique healthcare apps were downloaded just in 2012. At that time, there were almost 100,000 health applications at the time. And now, searching for health information is the top 3 reasons anybody is on the internet. So how is it possible that the majority of our health system in Canada are somewhat not digital or not very digitally connected? I'll speak to that in a couple minutes on some project work we've done. Lots of people tell me, oh, and you know, the whole digital thing is not going to be that relevant with the baby boomers who are going to need healthcare. The market analysis would suggest otherwise. The fastest growing market in digital tools, platforms, tablets is actually seniors. Why might that be? How else are they going to stay connected to grandchildren? That's where grandchildren are. Grandparents will always go to where grandchildren are. So the mobile healthcare market, do not assume that that is not one that seniors are going to engage in. It is accounting for 27 billion in revenues last year, and it is growing at a rate of 360%. Very few market segments are growing that quickly. When you put all that data together, really what's the relevance for health systems and health innovation? I think it's really about our society, and our Canadian population relies very heavily, and I would go so far as to say expects transparent and real-time information. The question we need to ask ourselves is, are we actually providing that in the health system? We go online to book flights and travel pretty much anywhere. You can go online and get a 10-year passport and never meet anybody. You can purchase pretty much everything online. You can now actually have your groceries delivered to you online. Ask yourself the question, how much in terms of healthcare and engaging clinical teams is also online? It's pretty limited. We have the same expectations for healthcare as consumers as we do the other day-to-day living we have, except healthcare is not there. And one of the challenges I think we're seeing in healthcare is a growing frustration, or maybe it's better described as a declining confidence. Nick Nanos reported a couple of months ago, he did a survey of Canadians, random digit dialing survey, and asked them how confident they were in their health system, and it was in about the 30% range. 2 years later, it's fallen below 20. And part of that is because they're increasingly disconnected. And increasingly, they're creating their own health systems around them. How many people do you see wearing Fitbits? Or you go to a gym and all you see is the trainer on someone's iPhone telling them what their next routine is. People are gravitating and using those online tools, whether they're good, bad, evidence-based or not is up for grabs, but they're actually increasingly becoming disconnected from health systems, and yet they're missing the very team of people that could help them stay well, preserve quality of life, and maybe even prevent those chronic illnesses. We talk a lot about the triple aim in healthcare, and the IHI, triple aim model is population health, experience of care, and per capita cost. I would suggest, this is just the Snowdon thinking, but do as you wish in terms of whether you believe it or not. I think we're moving from that system focus, which is very system oriented and provider centric perhaps, to a consumer focus. Consumers want 3 things, and this is how they define value. Is it convenient? Like, could I even get to access that service? Does it cost me anything? And I don't mean in writing a check to pay to see the doctor. I mean cost in terms of leaving my work place. Cost in terms of babysitting, cost in terms of traveling to get the specialist care you need. And did I have a choice? In our patient satisfaction surveys in hospital, the one question I love is, would you recommend this hospital to your family, friends, and neighbors? Well, in many Canadian communities, do we have a choice? Like, there is only one hospital, and unless I get a referral to another one, there's no option. So I think the more you think about in terms of innovation and digital tools and devices, think about the value proposition for the user. And if we're not assuming and we're not considering whether consumers, i.e. patients, if you wish to call them that, are going to adopt and use your technology, then quite frankly, you don't have much of a market. Because the future is going to be managing and supporting self-management, which means it's a consumer adoption piece as much as it is clinician. So future health systems, in my mind, are how well and how quickly we connect to the populations we serve, and in such a way where we're mobilizing, engaging them as partners, not just simply websites that tell you the 5 things you should do to stay healthy or the 5 food groups you should or shouldn't be eating. Our use of digital technologies, of course, is improving, but let me give you an example of what I mean by we have a long way to go. Colleague of mine was not feeling well, went through the usual workup and assessment, and they went through the cardiology, Holter monitor, all that good stuff. And she got a call Saturday night, one night, 9 o'clock at night, from a particular cardiac center that said, you need to go to emergency room right now. Kind of an odd call to get at 9 o'clock on a Saturday. And what does she do? She calls me. Well, I'm a 7-hour drive from her, and I know nothing about cardiology in adults, and I'm hard-pressed to know it even about kids when I used to look after them. All to say, she ended up in Emerge. She had required a pacemaker, had the pacemaker inserted, all those good things. She'd had arrhythmia with lots of big blocks that were pretty scary. And one day, a year later, she was sitting in a research meeting with me, and she started to look a little pale, sweaty, put her feet up on the table, pretty weird thing to do in a research meeting. And I thought to myself, and she's texting someone to say, I think you might have to tell your mother to call 911, which was my daughter at the time. All to say, I asked her, like, what's going on? She said, I had this lightning bolt of pain through my chest during that meeting. I really thought something had happened and I needed, either my heart would stop or I needed to go to Emerge. But she said it went away and then I felt fine. She called her physician at this particular heart center and they said, oh, don't worry about it. We were just testing the pacemaker batteries. Make sure they still work. It's like, okay, you were 600 kilometers away from that patient and Bluetooth enabled, you can test a battery by giving it a quick shot. Great. Why didn't we kind of think about the plan with that poor lady who almost thought she was about to say, the Holy Rosary and the whole 9 thing. And I don't mean any slight against cardiology, I really don't. But we've enabled these devices, but we haven't built our infrastructure into our health systems to make them work for the clinician team and the patients who could probably benefit by them. So that was a bit of a funny story at the time. She laughs now, but really it speaks to the potential I think we're not getting to. And the other thing I think it also speaks to is the whole issue. We talk about personalized care, personalized medicine. Personalization usually means, in most people's mind, the genetic therapies that are absolutely designed to an N of 1. And that has potential phenomenal opportunity. I think there's a whole other dimension of personalization, particularly with baby boomers. And when we really look at our population and our population segments in terms of needs and values and what they look for and what they will engage in, it's not about your disease and your pathway and have you got your sugars where you'd like them to. Clinicians worry about that and they need to. I'm not suggesting they don't. We rarely ask them what they're looking for, what are their health goals, and how do we help them get there. I'm going to just skip this to this case. And this is a study we did in the Southwest on patients with multi-comorbidities. I'll call this gentleman Jim. This is not him, of course, but it's a great illustration of him. He had a long history of COPD. He's had at least 1 or 2 strokes. He's on 24 different medications. He has 8 providers going into his home, visiting him every week. In the last 14 weeks, he's had 8 admissions to hospital and multiple emergency room visits in between. We put an integrated care model in place, and this is your 5% of high users in Ontario. And the first thing the care model is very simple. Just put a case manager nurse with each one of these individuals and figure out how to make it better. Because really there is no clinical pathway with that many comorbidity diagnoses. First thing the nurse manager said, or caseworker said to Jim was, how can we make your life better? How can we help you stay well so you're not here every week? And he said two things. What do you think they were? Number one, can you get my wife to stop yelling at me? Like, okay, that's hard on a good day. But it speaks to stress going on at home, right? It was just him and his wife and a small apartment. And the second thing is, can you get these people out of my house? And at a point, there was a point where she thought, okay, maybe it's a bit delusional. What people are in your house? 8 different CCAC home care workers were going into this man's house every week. He said it's like a freaking front door of Macy's on Christmas Eve. They're all coming in. They all have great intentions. They're all program-centric. They all want to help, but not one is really connected to the other. We took all 8 of those people out. We worked through what was happening with the wife, and the issue with the wife was she's terrified of mixing up 24 different medications at different times and different days. So we got a fishing tackle box at Walmart, and every one of the little lure things at the top were labeled. Monday morning pills, Monday afternoon pills, etc. After 10 days, he came, the case manager checked in with him and said, how are you doing? You know what he said? I haven't felt this good in 30 years. For the first time in 3 years, I actually got in the car and went to Walmart because I wanted to buy you a little present, and he bought her a dollar store flashlight. What really illustrated the importance of changing how we're looking after these patients. We have 300 of these patients in this study in a small rural city nearby a referral center. Every one of them have about 4 comorbidities. Every one of them are in the frequent users, constantly in emerge and getting hospitalized because we're not staying on top of the combination of their comorbidities. In terms of demographics, they all live below the poverty line. Over 60% never finished high school. So the social determinants of health here play a big role, but they're in their communities. They're doing their best to manage, but their default is emergency room because we're not actually managing what they want to have happen. All he wanted to have happen is, can you just help my wife sort out the medications? Because when you screw them up, he turns blue with COPD, and you have to go to emerge. And help him manage all these people coming into his home. We ended up putting one friendly visitor, an EMS visitor, who would drop in and say, Jim, how are you doing? I'm going by the grocery store. Do you need anything? That's all he needed. He died 8 months later. He was very much end-stage COPD, but he had had 8 months of phenomenal quality of life. When you look at the metrics that we measure in terms of health system performance, we don't measure quality of life very often. I measured wellness score. I measured a bunch of things on this population. Wellness scores in this generation, in this group of high users, they actually define themselves as having normal levels of wellness. He didn't see himself as multi-comorbidity and ill and, you know, on the edge of a cliff. He saw himself as just having a quiet life and just help me sort out the meds so I can do what I want to do. And that's really the magic, and this is not rocket science. Just helping him manage and staying connected, he probably could have done just as well with a digital platform that allowed him to check in with a clinician, a nurse practitioner, whoever his case manager was, just to help him stay on track with his care and have a quality of life that mattered for him. What we really have in front of us in health systems is we have phenomenally complex patients. There are not many clinical trials that'll tell you how to manage people like Jim. And oh, by the way, of that 300 people, they change. So the 300 people in September is not the same people the following February. It's an ebb and a flow. So given we have no ability to track and trace what patients, what products, what care are they receiving, we don't even actually know who they are. And one of the objectives of that study was to test a new software so that as soon as you swipe your OHIP card, what shows up is exactly where's Jim's been, who he's seen, what care, for what diagnosis, and what kinds of treatment. So a clinician knows exactly what they're working with. And that's just one example of a technology that was a game changer for those 300 high user patients. And by the way, when we measured utilization, We dropped their hospital visits over 50% for that population, pre and post, and we dropped their hospital days 56%. So we actually made the dent on the costs of utilization of the system simply by creating a very different model of care for them and personalized to everyone. We had 300 different care strategies. We didn't have one that fit all of them because these people are, every one of them are very unique. Digital technologies have a huge role to play in terms of how you personalize care. This is an example of a digital version of an e-MOCA. Instead of sending people to neurologists to have their risk factors for cognitive changes, we put it on a tablet so they could do it at home. And it was very successful. The only catch was it was very difficult to commercialize because the person who developed the e-MOCA didn't want it commercialized. So that's a different problem, different story. Only other thing I'll just quickly touch on, because I know we're a bit out of time, is really if we're serious about changing the game in health systems, it's about tracking and tracing and understanding what is our patient population, what care are they receiving, from whom, across the entire continuum of care. The NHS calls that a single source of truth. A really easy way to do that is simply using supply chain tools. Like they do in the grocery store, they barcode every product and they map it to every consumer in every store. A simple barcode of a patient ID, barcode every product you use, and NHS is actually barcoding every clinical team member that works with that patient so they know exactly what patients are in what rooms of what buildings receiving care from whom. And some of those settings have even barcoded the clinical expertise of those provider teams to know if you happen to have a student who's the first time has never done that particular procedure, one hospital even barcodes that student's barcode to know whether they should in fact be offering that care to that patient. We have a long way to go in terms of supply chain, but it is probably the one area that can not only create massive value for patient safety. Imagine if we barcode every patient, every product, and every care procedure, and in real time, you know exactly where your patients have been and what care you've offered them and what outcomes that care achieved. What supply chain really offers is rethinking the clinical environments our teams work in. So as a nurse, I barcode an armband, I barcode the drug, and if it comes up red, it's the wrong drug, or there's something wrong with that drug, so it stops me from giving it to that patient. So it's actually a proactive, preventive system. It'll even on the barcode scanner, and some of them say, that's an expired drug, don't get it, or don't give it. So supply chain is an area we're doing a lot of work in, and that's the 5-country global network. This is a quick illustration of what supply chain looks like for industry, Amazon. And by the way, Amazon is very big in healthcare. You just haven't seen them yet. Amazon used drones, and in an Ontario hospital I spent some time in when my son had his pneumothorax repaired. That's our supply chain. It's bins with labels, and and everyone's nodding, right? Do we still have those? Yeah. I sat there because I had nothing else to do when my son was waking up, and just watched tons of staff trying to find stuff. There are studies that suggest nurses spend 42% of their workday looking for things. If you had the Amazon version of supply chain, we would actually have a completely different clinical environment, where every surgical procedure, you barcode the surgeon, and then you barcode the ID band to, guess what, make sure the right surgery is happening with the right patient, and it's tied to a patient's chart. I was with the CEO of a hospital literally a week ago in Montreal, and he said, Anne, I learned about supply chain really early as a kid. I thought that was a bit weird. I said, really? How did that happen? He said, well, I was in hospital. I had a chronic illness as a kid, and the little boy next to me was going down for surgery to have his tonsils removed. And they brought him back from the hospital, and he was crying, and he was in a lot of pain, but he was holding himself down by his genitals. And his parents said, well, what? Do you have a sore throat? He said, no, my throat's fine, but it really hurts down there. He'd had a circumcision by mistake. So shouldn't happen, but it does, right? And all I can think of was, imagine that mother saying, you did what? He was supposed to have his tonsils out. And some poor kid had his tonsils out that didn't need those out either. But It's a simple fix. It's a barcode. A patient ID maps to the surgeon that's got signed the consent form that maps to the barcode in the patient chart to know this kid needs the circumcision, not the tonsils. But yet, as something as simple as that, we don't do that. And the errors in the system are really one of the major contributors, is because we don't track. Retail does. I can't even get on an airplane unless they barcode your boarding pass, and you see the big green check mark that says it's okay for her to board the plane. Imagine doing that in the operating room or even in admitting. To know that we actually don't know where our patients are in our health system, when they're waiting, when they arrived, where they're going, because we barcode and we track nothing. It's creating a whole different transparency. I won't spend a lot of time on it. But when you barcode products and you instantly know which ones are expired, which ones are not, they are saving so much money on inventory. Some organizations are reporting $8 return on every dollar you spend putting the barcode system in place. NHS is doing it for the entire healthcare system conservatively, because they're not measuring any of the patient safety outcomes yet. It's a $4 return on every dollar spent. So it's the one area of innovation in healthcare you could scale across the whole of the system, and it will pay for itself, because the inventory savings alone saves on all those products we order, never use, throw out because they become expired. Transparency then starts shifting accountabilities, and so will consumers shifting our accountabilities. It is a much more level playing field than it ever was. Access to information will change how surgeons and clinical teams work with our patients. It's a much more lateral collaboration. Surgeons now in those NHS hospitals at the end of every case get a grocery store looking slip that tells them to the penny what they spent on that case. So what happens is one surgeon compares to another surgeon and they say, well, how come I'm $300 more in my case than yours? In the US, if a surgeon is $300 or $400 more than the average, they no longer allow them to do certain volumes of surgeries because they're too expensive. So it is really changing how clinical decisions are made, how many processes are completely going to shift in terms of value and outcomes. Patient experience, I won't spend any time on this, but you know, in every other sector, when you go to a hotel, the TripAdvisor survey comes back, how'd we do? Can you imagine doing that in healthcare? You were at a clinic, how was it? Did we make a difference? I think we have a long way to go on measuring health systems. I did a bit of work with consumers in terms of measuring what's important to them versus what does a health system measure. Well, you all know, health systems we measure, did you know, morbidity, mortality, did you live, or did you have some complications? Did you get infected, readmitted, adverse events, wait very long? What consumers really want to know is, did it achieve my health goals? Did it improve my quality of life? And did it achieve the things that are meaningful for me? And I think really that is where the quality agenda needs to get to. Buckminster Fuller said you can never change things by fighting the existing reality. In my opinion, I think we've been fighting the existing reality for kind of a long time. In patient safety, and it's not wasted. We've talked about cultures of safety. How do you know if your culture of safety is doing what it achieves if you track and trace nothing in terms of outcomes or the number of times an error might happen? If we're ever going to get to system transformation, we need to build the evidence not just for what does that new technology achieve, but what does it achieve at scale and across an entire system in order to drive economic value, both for the system, but for those companies, but also in terms of driving value for patients. Why do we need to innovate much faster and more? I would suggest, and maybe it's the pediatric nurse in me, the next generation of kids desperately need us to, because this is a generation that really, really needs us to focus on their health and wellness and moving forward. So with that, let me thank you for the opportunity to speak with you today. Happy to take questions. I also know, though, time may be short, so forgive me.
Thank you very much, Dr. Snowdon. That was a very informative and inspiring presentation, as usual. It was also very interesting to hear about the future of healthcare systems and the approach to innovation. And specifically, I was very interested to hear about the efforts at the World Health Innovation Network, and I'm sure our innovators will find this resource very useful. I would like to open up to questions. So, please go ahead.
Yeah.
You mentioned that one of the needs would be for a service or platform that can help people take care of their parents and their children. I'm familiar with one of them in that space, and then the bus is validating. What can your group do for a company like that?
So a platform where it's got some evidence behind it that it looks like it's working, the work we would do would be partnering with that company, brokering a relationship with a health system, either a region or in the case of a province like Alberta, which is one system, and looking at the opportunity of how do we embed it and scale it and create the measures of impact. The last thing you want to do is embed a new technology in a system and have no evidence that it's achieved any value, because every other jurisdiction in the world is going to say, well, how did it work in Ontario? So what we do is actually create those measurement frameworks and get us out of the usual frameworks that health systems measure, create the evidence of value, economic opportunity for the system, but also market access for the company. Many, many times, companies come to us and say, you know, I've got this really great technology and it does A and B and C. And the moment I get a sense of what that A, B, and C is, the other thing we spend a lot of time on is there's probably 7 other applications you should be thinking of, and these are the countries that would be most, because of their strategic priorities right now, interested in adopting it. So to some degree, we'll do a bit of that engagement in terms of market access.
Any further questions?
Yeah.
So to your point about how there often are communities where you don't have an opportunity for some competition to shop around because it is your sole source provider.
Right.
You know, there are advantages and disadvantages to that. You go to the States, in certain towns, there will be 5 hospitals that do cardiac procedures, but they're all done at 1 o'clock in the afternoon, and the doctors do 50 procedures a year, where in Canada, similar doctors might do 250 to 500 procedures a year.
Yep.
Where do you kind of, but the advantage of the American hospitals is, from an innovation perspective, they compete with each other. And so you might get a little bit of benefit from that. You know, if you have a sense of how those sort of balance out against each other, and how we make
That's a
the
good question.
Canadian healthcare system perhaps a little more competitive in terms of providing the best it can to patients while living under its current constraints of costs?
Yeah, it's a really good question. And the one thing Canada and most actually publicly funded systems don't have is the revenue driver. If you have a technology in the US health system that can demonstrate a 20% savings or 20% increase in revenue, you have them at hello. They just adopt it. They're also in last place on the amount of money they're spending per capita. So it's a system that's not at all sustainable. But the value of that revenue driver is huge. We have, and you know, this is a subtle nuance that I'm seeing in a lot of the provincial work I'm doing. We have this weirdness in Canada, and if you have any insights, I'd love to have your thoughts on this. We have this competition thing that happens, but it actually gets in the way of scale. So it'll say, you know what? That's a Sunnybrook solution. We're not Sunnybrook. We're Toronto General or UHN or whomever. So we'll compete with each other to replicate a really brilliant idea and product that we should just work together and scale on. Same at a provincial level. So one of our other problems is, yeah, Alberta figured out the Alberta hip and knee strategy. Absolutely gold standard in terms of evidence, outcomes, all that great stuff. That was 2006. We don't have a hip and knee strategy in any other province. You know why? Because every province says, we're different, we're special. So one of our problems is competition is alive and well, but it's really getting in our way. So if you're a new Canadian company, and most, by the way, companies in Canada in the medical devices space employ, what, fewer than 50 people. How is it you're going to knock at every door in every different provincial jurisdiction to get your product to scale? We don't have the pathways we need to scale quickly and easily, and that's an area we absolutely have to get to because we don't have the opportunity of competition. The other thing that competition does in the States is they throw a lot of technology and stuff at patients because why? It drives revenue. Does it achieve outcomes? Not so much. In the Detroit hospitals, where about 3,000 Windsor nurses staff actually every day of the year, they will tell you, Anne, we're doing pretty interesting surgeries on a 93-year-old that probably would have been just fine had we left them alone, but it's a case and it means revenue. So it's a real double-edged sword. Do I have an answer? Not at all. But this weirdness around competition and we have to be different I think is getting in our way, in the Canadian landscape. And unless we have the Minister of Health that says, guess what, Sunnybrook figured out this model for X, you're all going that way, figure out how to partner with them, then I'm not sure how quickly it's going to happen. Creating the evidence, they say, oh yeah, we need evidence. I've seen them make decisions when the evidence is missing to adopt something with no evidence. And on the flip side, I've seen them adopt things where the evidence is actually slim. So it's a good question, but we don't have the revenue driver behind us. That could be a good thing in some ways, but not in others. Yeah.
I wanted to make a comment. You mentioned 8 CCAC or 8 workers going in. One of the biggest problems with our system is the silos.
Yes,
and
absolutely.
You mentioned UHN, Sunnybrook, and
there's
no communication,
yeah.
so people don't have their OHIP card. I mean, there was in the 70s, everybody was scared about their information being used. And so from that point on, no records have been shared between any institution.
Yeah.
eHealth is starting to work, but not well. Sunnybrook still doesn't have digital records. They scan the paper in to a digitized repository. So the charts are still not.
They're still paper-based, essentially. Yep.
Able to be searched, linked to the individual patients. If somebody can get over that sort of hurdle, that a patient coming from a town like Alliston down to here has to have their CT redone.
Yeah.
Just because nobody here knows that the HDERS has all the images in there.
Yeah. It's so true. If we just started on that, we would save this health system probably, I don't know, 40%. Mercy Health System that put in place the tracking and tracing, and this is not just hospital care, right through to the community, increased their revenue 28%, like overnight in the first year. So the system actually pays for itself and still makes money. Why aren't we doing that? How hard would it be to get every GTA hospital in a room to say, okay, let's do it collectively? Probably hard. I don't know, but I ask that that's actually what it takes. Because if you don't all use the same kind of barcode, like a global standard, then you still can't talk to each other. Now you've just got disparate data sets instead of, essentially images of pages on a chart. This is dead easy. Like grocery store CEOs say, Ann, I cannot believe you are telling me that today, if we recall the Boston Scientific stent, Ontario cannot tell me who's got the stent in that chest. Now we could if we spend enough time going through charts, but generally we can't tell. Cardiologist said to me, Ann, here's a bare metal stent, here's a drug-eluting stent. This costs $5,000, this costs $10,000. No idea which one has the best outcomes for which patient population. I find that odd. I find that kind of unacceptable if I need that stent, right? But that's exactly where we are. I couldn't agree more.
How there was some comparison of Canada for like all the other countries. Are there comparisons of that between provinces, or like is there?
Yeah, that's a good question.
Standards there, like how does that kind of be like?
So those numbers on the Commonwealth Fund are the mean of all 10 provinces, 3 territories. So there are some rock star provinces and not so rock star. So you kind of get the regression to the mean. There are some provinces that spend more per capita than others. The catch with that is you've got to look at the population segments. If you have a province like Alberta or Saskatchewan that's spending, 40% more per capita, but they have a 52% of their population coming from Indigenous communities, that's a different population. So a GTA population doesn't look anything like the rest of Ontario because no one else in Ontario has that cluster of hospital expertise in the whole province. So we have very significant differences in health outcomes for rural populations versus urban versus major teaching center. And it's to some degree it's access, but there's an awful lot of work we need to do on population segments. What works for women in cardiology may not look the same as for men. Age groups different again, certain cultural groups different again. We track and trace nothing. We really have just clinical trial data, which is great, but it's pretty controlled. They don't have multi-comorbidity patients in those trials. So many clinical teams are flying a bit blind in terms of what we think of as, and physicians are magical in terms of figuring out, look, I've seen this 47 times before, I know this will work. And they usually get it right. Wouldn't it be nice if you didn't have to see it 47 times and you'd know it would be just a little sooner? And that's the issue with error. I mean, I didn't talk a lot about, there are certain products right now, like a hip implant that was put in between 2007 and 2009. It's called the Dupuy implant. This is all public data. It was put into about 500,000 patients globally. After about 3-4 years of those patients receiving that implant, they had a very odd group of patients showing up and emerging total cardiac failure with otherwise no history of cardiac disease. Why is that? And they did some blood screening. They have toxic levels of cobalt and chrome floating around. There is no chelating agent we can give them to pull that cobalt and chrome out of a bloodstream. So a number of these people are disabled and or transplants because there's nothing else you can do for that cardiac muscle. But the catch is we waited until there's 500,000 of these people to figure out it's a problem. If we were tracking and tracing outcomes, we would know hopefully in the first 10,000. But now that we've got every major country in the world trying to figure out who has that implant, and the only way they're doing it is through class action lawsuits, and they put a Google ad in the margin on the right that says, if you had a hip implant between 2002 and 2009. A colleague of mine who's a dentist in Northern Ontario said, well, that's me. Sure enough, he's got not 1, 2. He has 3 times the toxic safe levels of cobalt in his blood. So now he's having cardiac workups every 3 months. It's crazy amount of money now just to keep him going and figuring out what are you going to do with that toxicity. So.
Are there any attempts to like standardize level of care like because there are those problems exactly?
Well, CONSUI has a pretty good measurement framework and system, but when you say standardize, I'm not actually sure what that means.
Like kind of like level the like quality of care, so like get people up to the same.
We don't measure quality outcomes generally. Did you live, die, get infected, wait, longer or shorter lengths of stay? Generally, we don't measure quality. We don't tie outcomes, really measure any outcomes to processes or care procedures. So there's no real standard, which is also a problem. I don't know if there's, there's probably lots on here.
There's a couple of questions here.
Okay.
Yeah, one question is about how do we take competition into account?
Yeah.
And I'll give an example, like if companies A and B develop such a traceability supply chain system, if they don't like each other and they might like run into issues, what can be done about that? The second question here is about the World Health Innovation Network and what is the common challenge that companies say they face in the Canadian healthcare landscape?
Okay, that's an easier one. Let me go back to the first one. But at WIN, what's the most common challenge companies come to us with? Bar none. How do I get this product into healthcare systems? Who do I talk to? What door do I open? And the answer is there isn't one. It's a very big challenge. The second one for companies that are in some system settings is how do I scale? And that's one we're spending a ton of time on. On the first one, if 2 companies developed a traceability supply chain system, actually you don't need to. The companies already exist. They're in every other sector in the world. All we have to do is actually get them to talk to us and figure out how to map into our current information system. Most of the ones that are currently very busy, the one company in the world that has a complete end-to-end solution from manufactured product right to patient outcome is a Canadian company. It's based in Montreal. The company's name, oddly enough, is called Texas. They don't have any Canadian clients. They're too busy implementing their system in the US and Europe. For me, that's a challenge. So I'm dragging them kicking and screaming to Canadian health systems. If Sunnybrook wants to maybe think about that, call us, because Laurie and I might as well. I'm thrilled if Sunnybrook is interested in that kind of thing. It's actually not that difficult. It's just we haven't done it. And legislative, this person is also, we do need legislative support. Mostly the only policy support we need is to make sure everyone uses the same global standard barcode. There is only one. There are others that are non-standard, but the last thing you want Canada to do is adopt the one no one else in the country is using or no one else in the world's using. Because if that hip implant in UK shows signs of problems, you want to have the same opportunity to know that that particular implant, lot number, batch number, and the exact implant is the same. So global standard, there's only one. So it's not a tough question, but it would help and it has catapulted every other jurisdiction in the world forward, simply by having Secretary of State Hunt in the UK say, we're doing it, everyone's going to adopt that global standard. However, these companies, they can manage any barcode because they have to, because the market's not quite there yet. But it's pretty easy. And there's so much work. Two companies would be busy enough, not even if they didn't like each other, they need to spend no time together anyway, because there's 152 hospitals just in Ontario. Lots of work for everybody.
Okay, yeah, so I think,
Thank you very
Dr.
much.
Snowdon.
I'm sorry I
That
took
was
probably
great.
more time than you
Yeah,
wanted.
thank you everyone for joining us tonight. One final reminder for medical biophysics students again, the orientation session is going to be hosted here next week on Thursday at 4 o'clock, just right before Dr. Courtney's lecture. Once again, thank you. If you have more questions, want to reach out to Dr. Snowdon, please do so. Thank you again, and I'll see you next week.